presentation which will be showing the posterior capsular tear. So this is one of the dreaded complications that we all know and we all fear from our first year in residency. So this was a hyper-mature cataract, and as you can see there is a lot of movement, and you are doing phacoemulsification, and now you are doing the cortex aspiration. So the cataract has come out peacefully, and we are doing the manual irrigation aspiration with the AC maintainer and the single port cannula. So here you feel that the cataract has come out very nicely, and you go ahead with this. As you can see over here that the phacoemulsification has been complete and you are relaxed, but what has happened is while doing the aspiration of cortex there was a PC tear. So what do? Either you leave it like this, luckily there is no vitreous prolapse, but this is now converted with viscoelastic into a PCC so that the flap won't trouble you, and a central PCC has been done. Use of viscoelastic is very, very important, and in this case the IOL in the bag is possible. This is the first case again where we do phacoemulsification. Here we are doing a stop and chop. This is a reasonably soft cataract, and we go ahead with the phacoemulsification. As you can see, what you see while you are finishing surgery is you can see this movement, and you know that what has happened is that while doing phacoemulsification you have left the safe zone, ventured slightly into the periphery, and as you can see now there was this moment where there was a slight hole and you went deeper and the PC tore. So what you do is there is cortex but the vitreous will interfere, so a vitrectomy is done and then the IOL is put. So never go too deep into the trench of the soft cataract was the lesson that we learned there, and not to leave the safe area within the rexes. This is a posterior polar cataract when we start surgery, and to do small multiple points of hydro procedure, which will be hydro delineation. Now in these cataracts, even though you see them on slit lamp, and we do not have OCTs to see whether there was a frank dehiscence or a defect, you go slowly, multiple points of hydro procedure. The cataract is extremely soft, and as you can see there is a crater effect, so it is difficult to divide. There is a crater or a saucer formation, and the pupil is very, very small. Phenocaine can be used now to dilate the pupil and to see where we are. So what you do is to lift one of the pieces because there was no other option left, and to try and rotate the epinucleus with the cortex that is remaining. The pupil is slightly dilated. This is the epinucleus mode in which the cataract is being done. So whether there was a dehiscence, whether there was a defect, which by our parameters increased, we do not know, but there was a PC tear. So again, all anterior segment surgeons need to have a vitrectomy standby to learn this anterior vitrectomy, because this is something that we to do it ourselves. Use tricot to stain and completely remove whatever vitreous is there, and then to put the IOL in the bag. Now a good rexis, the absence of vitreous can help us to put this inside the bag, and once it is safe inside the bag. Now here this is a mature cataract where we are trying to do phacoemulsification. There is no epinuclear buttress. This is completely mobile. It's now vertical, and there is no hold over the nucleus, and you are trying to do phacoemulsification. Now at any given point, this is a iris above, supra iris plane phaco, where you need more viscoelastic, and as you can see over here, this was a hyper mature cataract with the capsule, which is given away because anyway you are quite not really happy with the way things are going, and you yourself are uncomfortable when the nucleus is in the anterior chamber. So in this case, to try to do anything further would be difficult. The nucleus will go in. So this IOL scaffold, which is invented by Dr. Amar Agarwal sir, is a good and a safe option, because this IOL then prevents this nucleus from falling down. Because once a nucleus falls down, then nothing is in your hands. What you have to do is now just transfer the case to the vitreous surgeon. But here with the IOL scaffold and the nucleus in the anterior chamber, you can do a phacoemulsification. What you have to be careful about is protecting the endothelium, which is not a very small thing, because if the endothelium becomes hazy or there are SKs the next day, the patient is going to question you. And even if you do not have anything in the second day, you know for sure that some amount of endothelium has been lost. But here you can do a case comfortably, and you can give good results. So posterior capsular tear can occur at any time in your practice while doing surgery. It can, like from the time I was doing residency, what I was always scared about was a PC tear. And what Sir said is that whenever something like this happens, it's better to take a moment to put visco, to think where we stand, how we can go ahead, because if you panic, then you are going to make the situation worse. So PC tear can occur at any time, but to handle it, whether we can go ahead, whether there are any nucleus pieces in the vitreous, whether we can go ahead, whether it needs an extension, needs a lot of thought and care, removal of the vitreous completely, and to give the results that the patient desire is very, very important. So once again, I would like to thank all of you for being here for the case presentation, and I hope that you enjoyed a complete video presentation of wonderful cases. If anybody would like to add and give us tips, they are all welcome. If any questions are there, they are all welcome too. And I thank you all for being here for this course and being with us today. Thank you, Shirish, for the lovely cases with coloboma. Thank you, Dr. Navneet, for the mature cataract, and of course Dr. Lahane sir for his tips and his teachings as always with the Morganglian cataract and with the IOL exchange. Thank you so much. I thank all the seniors and friends who are here today for this course. Thank you everybody. Thank you so much.
Thank you, ma'am, for the wonderful presentation. If I may ask a question, ma'am, which please excuse my voice, I'm having laryngitis. Which scissors are you using? Like, is it epsilon, micro scissors?
To cut the IOL?
Yes.
Yes. So there are special scissors available. We use micro scissors to cut the IOL. If you do not have anything, you have to be just careful that your scissors which you have in the OT, the extension scissors, the corneal extension scissors, are sharp enough to cut the IOL. But it is better.
Rexis, where there is fibrosis.
Rexis forceps would be very tiny to cut the IOL, and that would not do the job. So you should, like we have CTR rings or iris hooks, it's better to have one more forceps. What we do is when we are doing surgeries, we have these special instruments also autoclaved with us as a standby.
Madam, special IOL cutting scissors.
Special
IOL cutting scissors are available. Okay. Even sharp and long ones are available for cutting of the IOLs.
So not for cutting IOLs. I wanted to ask for capsule.
Capsule. Okay, so micro scissors, we have no financial interest, but micro scissors which are available from Epsilon is something that we use, and these are very, very good because if you do pediatric cataracts, then you know the capsule is very elastic. But even in patients where you are worried about getting a Argentinian flap, to use a good viscoelastic and use these micro scissors is extremely helpful, because the first thing that I learned in phacoemulsification is break the rexes and you break the commitment to phaco. So micro scissors, leaving aside the finance of the micro scissors, it is a good thing to have in your OT. May not be in every set because then they are very expensive, but you can autoclave these scissors or IOL cutting scissors, or have this as standby for every case that you do.
Thank you, ma'am, for teaching us ABC of phaco. Thank you so much.
I'm all of phaco surgeons and beautiful phaco surgeons. These are our tips and something that we are given an opportunity to present. I think in today's day, phaco surgery is a part of everybody's life, even if you are super LASIK surgeons like Rupal ma'am who's sitting here. So I think cataract is something that we all have to do to remove the cataract blindness in India today.
Thank you so much.
Thank you so much.
Thank you, sir.
Thank you.
Thank you very much. Yeah.
Can you come to the mic, please, dear?
Yes. How you? Madam, if zonular, zonular weakness is progressive, like in cases of pseudo exfoliation, so you should fix the IOL with the iris claw or scleral fixation. If the subluxation is stable, like in cases of traumatic cataract, some penile cataract, that cases you need to fix the bag.
I wanted to ask this question after your cases, like the cases which were the cases which had a very high grade of subluxation. You have still gone ahead and done the fixation with the Sione ring segments or whatever. Wouldn't it be easier to just do a scleral fixated this thing or an iris claw? So that is what I wanted the decision making.
In my practice, I see to it that I'll see to it that the bag should be preserved. And believe me, more than 120, 160 degrees of subluxation can get stabilized. You just do it once, you will do it forever.
So I can, if
Yes,
if it's okay, I can answer this question. See, putting an IOL physiologically inside the bag, that is the best thing that you would want to. We've been putting monofocal IOLs in patients in the bag, and Indian monofocals where patients are 6'6" and even N6, which is very, very surprising. So when you are putting an iris claw lens supported by the iris, though everything appears good, there is always a chance of cystoid macular edema. You are using the scleral fixation, and there is something from the interior of the eye to the exterior. So without taking any risk, if you think that the subluxation is such that the bag, like Dr. Sirish said, can be stabilized by Sione's rings or segments, and you can put the IOL safely in the bag without the whole thing subluxating or dislocating downwards, then that would be a better option, though the iris claw and all would look easier. So, and having said that, what you are saying is correct, that we've found cases where we've had patients referred to us with so many things inside the vitreous, including 1 or 2 lenses and 1 or 2 rings also. So everything has to be customized, but it can be done, and before thinking that no, it cannot be done, we can try this for the patient.
Thank you very much, ma'am and sir.
Yes. Sirish, and yes, ma'am.
Ma'am, I want to know what are the precautions we should take in case of very shallow phacoemulsification in very shallow AC.
So very shallow ACs are a part and parcel of our lives. You see some people who are very hypermetropic with small eyes. So use of a good viscoelastic, and when you go in, you have to, supposing when you go in, and if the tunnel should be correct. If your tunnel is big, it is leaky and the fluid leaks out, the anterior chamber would shallow even more. So before you go in, you should not use too much of flow of fluid, and once you enter the anterior chamber, you can press on the flow also, and use of a good viscoelastic which will form the anterior chamber, and try not to come out, because in patients who are on medications for prostate, there will be IFIS and there will be the iris coming out. So use of a good viscoelastic, because the space is very narrow, and you would like, there would be SKs also, plus it would be difficult to operate. And most of these patients with shallow anterior chambers also have very myotic pupils and undilating pupils, which adds to the problem of the shallow AC.
Sometimes iris is coming through the tunnel, all
Yes.
the time you have to push this
Yes.
flow again.
So what you have to do is, once you go in, do not start the flow and go in. Make the tunnel the correct size so that the fluid and the iris do not come out. Use viscoelastic and go in. Then start the fluid and try not to come out. If you have to wait, like sir said, that it's not bad to come out, but just to wait with visco, put visco through a side port, and another instrument through the side port to manage the iris, which would be a little comfortable.
Thank you.
Thank you. Thank you, friends. I think our time ends here
Yes,
too.
ma'am.
Thank you so much, everybody.